Ron, and welcome to this new session of online teaching. This time we're talking about neonatal cranial ultrasound from our perspective as pediatricians, neonatologists, or pediatric intensive care doctors. So, why do we use cranial ultrasound, and why is it used if we've got like CT, MRI, which might be more specific, more objective? Well, first of all, it's safe, easy, can be done bedside. It's reliable with good hands. You can rely on the result if you're experienced enough. The other point as well is it allows you to get early imaging. So preparing for a baby who's in intensive care to get a CT is usually a bit difficult because you need to plan for the transport. What if he was on the ventilator, stuff like that. And MRI is, well, more difficult as well because of the time that you need to spend there. So you can get an early image using a cranial ultrasound, even if you're going to get eventually to a CT or an MRI. It allows for serial imaging, again, because it's easier. And serial imaging helps with studying the brain maturation and the evolution of the lesions. So if you're following a hemorrhage or hydrocephalus, you can follow that using serial cranial ultrasounds. It's inexpensive in comparison to the other models. No need for sedation, which is a huge benefit because of the risk factor of sedation and the palaver about preparing for general anesthesia for an MRI, for an instance. Suitable for screening, which also is a very important perspective, because you need to always understand that our perspective as pediatricians or neonatologists or intensivists with a cranial ultrasound is mainly screening. We're not acting like we're as good as radiologists or radiographers. So we need to understand our limits or our window and why do we do stuff and what is the interpretation of the result that we're getting. But screening is always important as well. So what is our aim with neonatal cranial ultrasound? What are we looking for when we do a neonatal cranial ultrasound? One, excluding cerebral pathology or demonstrating it. We need to assess the timing of injuries. So again, because you can do it early enough, you can get an idea about when it happened. Because if you've like some units in neonatal, for instance, do cranial ultrasound with every transferred admission to make sure that they're getting the baby there, know the baseline, and then they follow up that 3 or 7 days later, especially with prematures. That's like a way to do it as well. Assess neurological prognosis. So some areas or some injuries can give you an idea about what prognosis you're looking for according to the ultrasound findings, when we're going to get to that with the next lecture. It helps making a decision about continuing neonatal intensive care. How does it help? Well, there are a lot of input about how to assess cerebral perfusion, for instance, so that you know if the brain has been perfused or massively affected. There are assessments of midline shifts, brain insults that are dire, cysts that are progressing in vital areas. So you can see a lot of stuff, and accordingly you can assess your decision, especially with a baby that you can't transfer anywhere because they're maybe hemodynamically unstable. You can optimize treatment and support according to some of the findings, and that all will be explained with our second lecture, which is going to go through pathology. But these are your aims of a cranial ultrasound scan. Some technicalities just to understand what we're doing. So you need to have a transducer, a probe basically, that is transducing wavelength of or wave frequency from 5 to 10 megahertz, because our standard examination uses about 7.5 to 8 megahertz with neonates. The size should be appropriate because you're you're trying to avoid any bone structure. So you're looking for tiny windows like the anterior fontanel or the posterior fontanel, and you're dealing with tiny infants. So as tiny as the baby goes, you will need higher frequencies to study their brain, because higher frequencies give you better picture, better resolution, and it's more superficial. So with little babies, you don't need a lot of depth, so you can appreciate a study that will get you more resolution or more details with a higher frequency. So you can go all the way up to 10 with some premature babies. But with as larger the baby goes and as older they go and as thick as their hair comes up, you might need to go a bit down with your frequency. So you can go down to maybe 5 megahertz or something. Okay. So starting with our probe position and our study, we usually start with the anterior fontanel, and we usually start with the coronal position. So that's how we hold the probe. So why are we putting this picture now? Because basically you need always to remember that you need to put your knob in the right position to interpret what you're seeing with the right orientation. So here the knob is pointing to the right side of the patient. And again, just to go through how we conduct our study. We usually start with the anterior fontanel, and we sometimes just do the anterior fontanel. Well, not sometimes. Most of the studies are just anterior fontanel studies, because anterior fontanel is your standard view. It's where you get most of what you need to get. But sometimes when you're in doubt or looking for something in a child that is a bit tricky with the anatomy, or with some advanced radiographers who are looking for something with that is related to Doppler studies, you can go through other windows. So if you're going to do that, you're going to start with anterior fontanel, go to the posterior fontanel as a supplementary window, and some people go as far as the mastoid fontanel and the temporal window. The temporal window is usually used even in adults. It's a window that keeps being there for you, even if you're studying older children and all the way up to adults. But as we're gonna explain later, most of the benefit you get from the temporal windows are related to perfusion and blood flow studies rather than anatomical structures. So as we said, we're going to start with our anterior fontanel and our standard view. So you start with the coronal view, which is this plane, and that's our first part of the study. We start with that because it's easy to screen the brain as a whole and make sure that your anatomical structure is in place using the coronal plane or the coronal views. You need to keep the knob to the right side, as we explained, from the anterior fontanel with this orientation, and we're gonna look for 6 different images as standard. So if you're freezing images and saving them, to make sure that you've got a good study, you need to go through all of these 6 images, and that will help with people interpreting your studies, looking at your images, rather than just having random images. That is never a way to do a study. Even if you're gonna maybe move the probe up, forward and backward, trying to make sure that you've got what you want, but as long as you've got these 6 images, that's gonna be what we're looking for. So we're gonna go through the images that we're looking for, and we're gonna call them, because we're talking coronal, we're gonna call them C1 all the way to 6. So C1 is the most frontal one, and you can see it's going just through the frontal lobes. So what are we looking at? Well, this is the falx cerebri, which divides the hemispheres to right and left. Now you're keeping the knob to the right of the patient, right? So in that case, you're just standardizing your image as what you'd expect from chest x-rays, CTs, whatever. So that will be the left side, and that will be the right side. And that's why it's important to keep your knob to the right side. So falx cerebri, frontal lobes, right and left and right, and supraorbital ridges, and the orbits. What would you get from this image is basically, first, your orientation. Make sure that if your bony structures are identical on both sides and your falx cerebri is that like that, then you know that you're holding the probe in a very good position because you've standardized your study. The other thing is you can find some flare here later if you're looking for PVL, for an instance, or some other abnormalities. You can sometimes find intracerebral hemorrhages. Most importantly, you need to make sure that the falx cerebri is in the midline, so there is no midline shift. And that's most of what you're going to get from this plane or this image. Then you go to C2, so you go a bit back to the frontal horns of the lateral ventricles. Things start to get a bit interesting and a bit difficult to interpret. So again, falx cerebri, frontoparietal hemispheres here and there, and then your anterior horn of the lateral ventricles. These slit-like black lines are your lateral ventricles. If you can see them, they're really thin, they're really slit-like, and that's how ventricles should be. They should be slit-like. This is your part of the midbrain. So I think that's going to be part of the maybe the thalamic nuclei or something. And this is the Sylvian fissure. It starts to appear here. So the Sylvian fissure looks like the Y shape on the side here. Why is it important to see the Sylvian fissures? Well, basically, Sylvian fissures should be identical on both sides. And if one of them gets a bit flattened, while the other is not, that might be a sign of a midline shift or a hemorrhage on some point that is still so tiny, but has got a pressure that is big enough to start cupping one of them, or flattening one of them against the other. So that's why also you need to be sure that your picture is in a good orientation before you judge the Sylvian fissures, but it's also good to look at them. And then your tentorium is that whatever goes there is subtentorial. Here is the temporal lobe, basically. And this is the anatomy of what we were looking for. So I take it back, it's the caudate nucleus, not the thalamic nucleus. What was there is the caudate nucleus as is shown on the anatomy surface. Okay, so we go to C3, or I would say that's the most important image that people keep looking for, and that's what we all try to get to say, oh, we've got a very good image. But actually that's fair enough, because at this level you can see the lateral ventricles, you can see the corpus callosum. So the corpus callosum are these two white lines, the white transverse lines that are just parallel to each other, and then lateral ventricle slit-like to the sides. And you've got here the septum pellucidum, which is normal in more than 15% of the population, but it's also important to mark because there are some syndromes where the septum pellucidum is a very important factor. And then here, what is marked with with the number 12 is the third ventricle. So you can see it's really thin, it's slit-like, right, and really tiny. It's really important to appreciate the sizes, because so the ventricle slit-like structure might be your first impression to understand hydrocephalus if you get some, which is important to mark early enough. And again, the midbrain area is always here to the sides. That is what was marked with the number 6. And your thalamic, your temporal area is here, and then or temporal lobe, and then 9 is the Sylvian fissure on both sides, again Y-shaped looking to the sides. And this is a very important view. This is the view that you would measure your ventricle size on in hydrocephalus follow-ups. It's really important to appreciate this view because as I said, it shows most of the structures you're looking for in your scan. Okay, and just anatomically, so midbrain wise, this is the part where you can find the medial thalamic nuclei and the lateral thalamic nuclei. So C2, you will find the caudate, the caudate nucleus, and on C3 you're going to find the thalamic nuclei, just if you're interested. C4, you're going to get a bit back to C4, and here you start seeing your choroid plexuses on the sides. And for the unexperienced eyes, this is the first time you see it, you'll say, oh, there's a hemorrhage there. But these are the choroid plexuses. It's really important to appreciate that they should be a bit more or less identical in size, in color, and in color is more important. This view is really important as well, because you can see the choroid plexuses. That might be tricky if you've got a hemorrhage. This area is usually like these two sides of the brain here, where the number 20 is. This is where you would find the watershed areas that can get preventricular achalasia in prematurity. And again, tentorium, and then you start your brainstem area here with the midbrain. So if you've got some depth with this view, you can see as far as the brain, at the medulla, which is amazing. With some radiographer, they can interpret all of that, and it's like, if with the experienced hand, actually, cranial ultrasound can be as good as the CT, but you need to have someone who's really, really good with it, who's really, really experienced and really, really sure about what they can get. And again, anatomical wise, this is what you're looking at. So you can appreciate the anatomical structures as well. Then you go a bit back to C5, and C5 is where the posterior or the trigone of the ventricles is. So trigone here, imagine you're looking through all of that. So now you're going to see the ventricles as vertical lines encroaching the choroid plexuses, because the choroid plexus sleeps here, goes like that from here to there. So if you're cutting that, you're going to see the choroid plexus going from here to there, because it lies all the way on the inner curvature of the lateral ventricle horns. So that's why you see the choroid plexus is like that. And then you can see here the cerebellum, the medial part, and the lateral hemispheres. Again, temporal lobes, and again, always scan for midline shifts. Be sure that the structures are not shifted anywhere. Okay. And then you go a bit back, and this is your area of the occipital lobes, right and left with falx cerebri. What are you looking for here is, again, just as C1, you're looking for flares, hemorrhages, midline shifts, making sure that you're not missing anything with your scans. Okay, so we finished the coronal planes. We've done our first set of images, the 6 images that we talked about, and now we want to complete our anterior fontanel testing. Sorry for that. So we turn the probe 90 degrees to get the sagittal view, which is, as you can see, is cutting the brain in posterior anterior, and you turn the knob to the front of the patient or the baby, basically. So here we're looking for 5 standard planes, 1 in the midline and 2 for each side. So basically you need to learn about 3 views and apply that for the right and left side. So if you start with your mid-sagittal plane, and that should be the standard, you should start aiming for your sagittal imaging or scan by finding the midline, because first of all, that's your standard, and it gives you a very good picture about what lies in the midline, and then you can go right and come left without worrying about the orientation that much, because the midline is always the part that you need to find. So as you can see here, this is the corpus callosum there, number 10. This is the bit of the lateral ventricles, either right or left, that you can see on the midline, because you can't really be 100% away from that. And then here, that will be the foramen of Monro. Third ventricle is the rhomboid shaped structure in here. This is the bit of the midbrain that you can see in the middle. And then you go down from the aqueduct of Sylvius, and you can find the cerebellum in the back and the brainstem going down here, which makes this bit your fourth ventricle, and then occipital lobe from here, and basically this is all the cortex. Okay, and then you turn either right or left to get your first lateral view, which will show you your lateral ventricle, either right or left. So anterior horn, the body of the ventricle going to the trigone and the posterior horn, and you can appreciate the whole structure being really obvious, to be honest. This bit here, if you look at it with this, there's a dimple here that goes like this. Just look at it right now. So this is where the germinal matrix is. This is where you would find your you would find the findings of the IVH grade 1, usually here just under the number 14. Choric plexus is lying here, as we said, on the inner curvature of the ventricle. Okay, and here is the midbrain, or like the condylar nucleus, the thalamic nuclei. They all lie here. Okay, this is where you might find most of the flares of the PVL, because this is where the watershed areas usually are. So these are all important structures to keep an eye on. Occipital lobe here, part of the cerebellum is obvious here. That's basically what you're looking at. Then you go further right or left, and basically what you can see is both is what lies to the peripheries of the sides of the brain. So temporal lobe, parietal lobe, occipital lobe here, and basically you, as we said, you're just looking for any flare, hemorrhage, cysts, or any abnormalities. Okay, and hence you finished your scan from the anterior fontanel, and basically you finished most of the standard scans that we do, because most of us would not do anything other than that. Just out of interest, just to as teaching points, we're gonna go quickly through the posterior fontanel, mastoid foramen, and the temporal window. So with the posterior fontanel, you can scan it coronally like that, putting the knob to the right as well. And what your scan is going to show is this bit of the brain. So the trigones, the posterior horns of the lateral ventricles, the occipital lobes, and the cerebellum are usually what you can see, and you can see that here. So trigones with the lateral ventricles, falx cerebri, and then cerebellum is all here. So basically, it can show a very good picture of the cerebellum, to be honest. If you're doubting something happening with the cerebellum, it's really good if you're looking for cystina magna or dendritic malformations, stuff like that. You can really have a good picture here. But other than that, it's not our best part of the scan, because we're not that expert with it. And then this is an image from the left temporal window. Where you're gonna point your knob to the front side like this, and you can see that it's cutting the brain at the level of the bones and the cerebellum, and just a bit of the the midbrain, the cerebellum, and a bit of the occipital lobe. And well, this is the image. So this is where you're looking from, and this is where the cut is showing. So it's showing the cerebellum from the periphery to the medial side and then the other periphery, and that is also applying to the brainstem here. Okay, but basically you can't really make a lot of that. But what we're usually looking at from the temporal window, as I explained before, is the blood flow and the Doppler uh, view. So you can really see and appreciate the circle of Willis here with the posterior cerebral arteries, the mid-cerebral arteries, and so it's really good for vascular flows and arterial flows studies. We're not the most brilliant experts with that as pediatricians and neonatologists, to be honest. But again, it's used in the adult world. And this is what we call a lower transverse view from the temporal window. So it goes through the temporal lobes as well. So you started from here again, cerebellum, and then rather than seeing the midbrain, you go through the pons and a bit of the medulla, and you can see the other temporal lobe on this side. And then there's the mastoid fontanel with the knob pointing to the upper side, which will show you what we call the coronal view of the mastoid fontanel. That's basically also studying the cerebellum. Mostly is just the cerebellum, to be honest. Again, good for dandiochrome malformations and congenital abnormalities related to the cerebellum. And the transverse view is not that different, but it shows a bit of the ventricular system, that's the only thing that's different about it, to be honest. So we're not going to spend a lot of time with the supplemental windows, just to not confuse you. I would say just try to be an expert with the anterior fontanel, and that would be your screening tool as a neonatologist or a pediatrician, or if you're a pediatric intensive care intensivist. So basically, you need to know what you're looking for. You need to know the normal to appreciate the abnormal. You need to get yourself a bit familiar with the probe, with the scans, as much as you can. Try to scan normal heads under supervision, um, so that if there's something abnormal, they can pick it up at least. But do that as much as you can with the support that you can get and under supervision to get familiar with it. It's not hard. It's not difficult. It's not as difficult as some scans like echo, because basically these are still images that you're looking at, so you can master them if you just be keen about it and try it more and more. The other advice that I would give is looking at images that are stored in the system that are reported. That would be a good thing as well to get familiar with what you're looking for or what to expect. This is the legend of the numbers on the images that we showed. If someone wants to go through the video, go back, make sure about the other structure that we didn't really mention. Next lecture is going to be about the abnormalities and the intensivist perspective about cranial ultrasound. So I would appreciate any feedback in the comments or following the link to the survey that is put in the description of the video. Thank you very much, and we'll continue with the next lecture that I'm going to add as soon as possible. Thank you very much.